So we come to court-martial in ophthalmology. And this is so court-martial in ophthalmology has been there for 2010, and it's a great 13 years of journey in court-martial in ophthalmology. So let's give court-martial in ophthalmology a big hand. And we began at Chennai, and it was a very, very creative team that took us through all these years of court-martial in ophthalmology. And today we have, you can see, the 105th session of court-martial in ophthalmology at midterm conference here at Vizag. So court-martial in ophthalmology has also gone international, and we've gone to Kuala Lumpur, to Singapore, to Bangladesh, and all these places have given great response to court-martial in ophthalmology. I remember in Singapore, the glamorous surgeons on trial, one of them were amazed and aghast and started crying because the rude public prosecutor took the lady on. So here we are, and I invite the supreme judges, our favorite supreme judge, Dr. D. Ramamurthy. Give him a big round of applause, and Dr. Harbans Lal sir. The courtroom shall rise to welcome. The courtroom has to rise. Am I being heard? The courtroom has to rise. Lady there, Manpreet, you have to rise. Dr. Reddy sir, you have to stand on your feet and welcome the Supreme Judge. Thank you, sir. Be seated, please. And we have this wonderful defense counsel who will never sit down, who is going to protect even the worst of the scenarios, the worst of the surgeons, and she is going to be a defense counsel for all those glamorous surgeons who have butchered their cases. Dr. Devashish Bhattacharya. So that's Dr. Chitra Ramamurthy. Thank you, Chitra, for being with us throughout this journey. Give her a big, big hand. And of course, I am here. I'm here to give you justice. I'm here to tell you that you cannot be spared, however glamorous you are, whether you come from Hubli or Trichy. You will not be spared. If you are the most beautiful ophthalmologist, you will not be spared. They are all here, sir. And now I call upon the honorable jury members. Some of them have taken leave of absence, but we have Professor Tityal, sir. We have Dr. Devashish Bhattacharya, we have Dr. Amit Porwal, we have Dr. Reddy, Dr. Reddy, Dr. Reddy, sir. And we have a very, very favorite jury member who is going to hang everyone. And that's Dr. Santan Gopal, past president of AIOS. Come, sir, with a promise that you're going to hang. Dr. Madhu Udraju, are you there? Madhu is not there. So we shall go over to Srinivas Joshi, Hubli. Here you are. Hand on your heart, Dr. Srinivas Joshi. All the music is going to end now, and your oath in Kannada.
ನಾ ಏನೇ ಹೇಳಿದರೂ ಸತ್ಯವನ್ನೇ ಹೇಳುತ್ತೇನೆ, ಸತ್ಯವನ್ನು ಬಿಟ್ಟು ಬೇರೆ ಏನೂ ಹೇಳುವುದಿಲ್ಲ.
Was that all right, sir? I'll start. So with your permission, we shall start the proceedings. Yes.
Okay, so here was a 15-year-old boy who got hit twice, once with a football and once with a tennis ball in a span of 15 days. So this is how, it was a completely closed funnel RD. And one of my fellow was quoting it like an Eiffel Tower. So I thought of just leaving up this case, but their parents were very much insisting to operate on this kid, though had given a very bad prognosis or no guarantee kind of types. So here what I'm doing is, after completing a vitrectomy, I'm just trying to unfold it using the light pipe and the cutter. I'm just trying to unfold and then put a PFO. Now you can see I'm doing a step-by-step PFO I'm installing so that the closed funnel opens up. But however, you can see there is a lot of blood clots behind the retina. I had to remove these blood clots one by one. You can see the subretinal gliotic bands there. And here there are a few more blood clots which were there. Remove most of these. And then again instill more PFO. So step by step PFO installation is definitely better, because we get to know where is the traction, where is the persisting traction. Otherwise the PFO will override and again come back beneath the retina. Now you can see there is a temporal traction still persisting in spite of using a PFO. That means that traction is still there. There was another subretinal gliotic band there which I had to remove it. And finally now you can see this is a small window of hope, which is what one of my colleagues was stating it, and finally we can see a very settled retina, the laser being done to the retinectomy edges, and then fluid air exchange was done, and this is how we can see the final look of the retina. Silicone oil was injected, but however after a month again I couldn't see the pupil at all. I thought it has again gone into the closed funnel stage. Now you can see there is a synechae there, entered synechae. I had to release that synechae, and then I had to do literally a pupilectomy using the cutter. And once I do that, I now go inside to see whether it has again opened up. But fortunately, only the nasal side of the retina had opened up. So you can see the subretinal oil going into the nasal part of the retina. So here that means that there was more traction on the nasal part, so I had to relieve those traction as well. The PVR had set in again in a month's time. I had to release that. Now you can see there is a subretinal oil which pops up. And finally, after doing a little more retinectomy to the edges and removing those blood clots and the subretinal gliotic membranes which had formed there, so removing these blood clots is definitely a challenge, because we can't laser until we remove those blood clots. And finally now you can see relatively good cornea. Now the PFO is instilled, retina is flattened, and the laser has been done to the retinectomy edges. And you can see the macula is flat, disc looks good, pretty good. And the peripheral retina also looks pretty stable, and silicone oil was injected in this case. And fortunately the patient is doing well till today. Yeah. Thank you very much for the presentation.
Big clap for that statement. Patient is doing well till today. Shall I begin the trial, sir? Yes. So this is a story of retinectomy. This is a story that how you can fleece your patient through multiple stages of retinectomy. Ma'am, put that mic down, please.
It's getting scared.
Okay. So the first and the only question that I think I should ask you is, why did you try and operate this eye at all? An eye with that funnel RD, with the no potential of any useful vision, all crumpled, trauma twice, the cricket ball and the tennis ball. And now the ball that you inflicted and did retinectomy time again. Why did you operate this eye? Dr.
Objection, Your
Srinivas Joshi. What was the final visual outcome of these multiple heroic surgeries, flexing your muscles, showing it to everybody that I am Srinivas Joshi? And how long ago? Is this retina going to stay stable over the years to come? It has already come off, and such retina can never remain stable for the rest of the life of such patients. Why didn't you remove, well, let's go into the surgical aspects of the case. The entire subretinal gliotic membranes, why did you not remove? And that obviously was what created
Objection,
the
Your
recurrence.
Honor. Objection.
Stay on that. The posterior hyaloid, after opening the funnel, and the residual hyaloid that you left behind, obviously you could not take it out, and that's what related to the recurrence. Inferior PI, why did you not do in such a patient? And what is the status of the intraocular pressure? Because with such a large amount of retinotomy that you have done, and this leads to hypertony, it's well documented, and that's what the practicality is. And what was the hypotonic status of this patient? For everything, and for the first question that I've asked you, why did you operate this eye? I find you totally guilty.
Objection,
Okay,
Your Honor.
Go ahead.
Yeah. I think a very meticulously done surgery. He has explained the prognosis and the patient has been doing well.
And fleece the
even
patient.
Please,
the primary surgery and the secondary surgery which happened was done well, and the subgliotic glands, whatever, can reform after the primary surgery. It wasn't that it was not removed in the primary surgery.
It
He
was
showed
not removed.
extensively how he went after every hemorrhagic area. Everything was cleaned up and the retina was flat. So it is not a question of the eye patient may lose his vision after a few years, so you don't give him good vision. I can't understand. You had a traumatic cataract, you won't operate on him because of all the
Not
imagined
with this
complications.
potential.
You should have said one thing which you didn't, but that's
Yes.
a saving grace for Srinivas, and I'm not going to bring it up.
Hang him.
Why should you be hung? You didn't say that.
The
Dr. Srinivas
patient had counting fingers vision in that this thing. It was up to 1/60 vision is what he reported with. So I think even in a child, if we attempt and try to give as much vision as possible, I think that will be the best part on the VR surgeon's life, because we are trained to do like that. One statement I still hear from one of the mentors from Shankar Netralaya, that even after the surgery, if the patient goes no PL, but make sure that the parents are happy and the patient is happy, because it was the best at that point of time what we could do for that child. And since the parents were insisting, I had already requested them that this is not going to be a futile, this is going to be a futile exercise, but they were insisting that we have to do it, and that's the reason I did it,
You
sir.
accepted that it was a futile
Let's
exercise?
let's have the comments from the jury.
No, Supreme Justice, I have a question to the public prosecutor. He said, why did he operate on this child?
Yes, sir.
I mean, what would it be if it was your child? No, everybody
Yes.
deserves
Yes.
Yes.
a chance. So my question to you is that.
We can hang the public prosecutor. The court martial rules have changed.
No, I am a corneal surgeon, and we face sometimes a similar problem, multiple grafts, and we still think there's hardly a chance of a recovery of vision on a survival graft, but still have to do it to give a chance to a person of, any amount. Some gain has to be there. I remember one particular statement, dialogue from one of the movies.
Be away from him.
where you have an assignment where you have a very little chance of survival. So this guy says, what is your chance? He says, sir, 5% of survival, but I'll go for 5% also. Same thing here. Even you have a little chance, we should give an opportunity for the physical anatomy of eye to remain, and maybe some vision comes back, and I think we have to keep on trying.
I think the rules of the court martial, as the defense counsel said, has to be changed. Because of public prosecutors of this type, why did you decide to operate this? Our doctors are getting scared to touch any traumatic cases. Because we have to reduce the quantity of these type of public prosecutors so that our doctors are not scared and they do the right surgery at the right time.
Amit Podwal.
Amit was always
Don't
on
scare my
my-
jury.
Amit Porwal is always with the defense counsel.
I agree that any child should be given a chance for some amount of vision, because that amount of vision for that child may matter. But then if the other eye vision is good, is it worth subjecting the child to so much of difficulties?
Bravo, sir. Bravo.
The first thing is, under general anesthesia, you're treating this child 4 or 5 times, you are operating. Now that itself has got certain amount of mortality and morbidity both. So that you need to compare it to the visual gain. You have never mentioned anywhere the amount of visual regain the patient has.
1 by
Had
60.
Mention
1 by 60.
Counting figure to 1 by 60 is not a great improvement.
No, it is enough for the boy to walk around, and one eye detachment, the other eye could also get detached. You never know what could happen. 160, as a glaucomatologist, I would kill myself to give that 160 to my patient.
No,
No, when the other eye is absolutely normal, I think.
So what?
Let's have.
If the other eye is perfectly normal, would you like to subject the child
Yes.
to so much of trauma?
100%.
You don't know the trauma.
What trauma? It was such a beautifully done surgery.
No, please listen to me. The psychological trauma of anesthesia for any child is significant. You must understand that
the-
anesthesia is not simple for the child's psychology.
No.
It may be simple for the anesthetist, but for the psychologically, it is quite damaging to the child.
the other thing is the
1 by
possibility.
6.
Sir, just one more question. The other thing is, and this is very important for every VR surgeon, the eye should maintain its anatomical
Exactly.
shape and size.
Exactly.
Where
exactly what I-
phthisis could have set
This
in
would have
and
gone in for
this-
thysis if
Thysis
left like
was
that.
Exactly the
prevented.
point I
And
wanted to
ISIS
make.
was prevented.
Yes.
And that could
this
have caused more
cosmetic
psychological,
disfiguration itself would have been
that could have
quite,
caused more psychological
psychologically
depression for the
Yes,
child
for
and
the
the
child,
parents if
yes.
it goes for thysis.
No,
Yeah.
but
No,
multiple
by
surgeries,
reforming
multiple
the-
surgeries.
By reforming the globe and giving it a shape, do you think the chance of PVR in these young children is much higher than in the adults also? There's chance of recurrence. But do you think once you do this surgery, the chance of going into phthisis is lesser?
Is
No,
definitely
visual,
lesser, but I agree there will be hypotony in these cases.
More,
for-
Srinivas,
So
more.
0.7 there will be, he's correct, it leads to hypotony, but with the silicone oil in place, at least some amount of integrity will be left over and the retina is still attached and the child still has 1 by 60 vision.
And I don't think you will contemplate silicone oil removal in this case.
No,
You'll just leave it behind
yes,
at least
yes,
to
yes.
maintain the
Yeah,
shape.
it's a 5000 centistoke silicone oil.
So
better left
basically,
alone.
it's more to reform the globe.
Reform the
and give
globe
it,
and give ambulatory vision as much as possible.
some anatomical integrity and whatever. The other
A
eye
little
is
bit of functional
anyway
outs
having
also. Yes, sir.
The most important part is the ability of the surgeon that counts a lot in these situations, and I found that you got that ability.
Thank you, sir.
Your this thing, guilty, not guilty.
Cards are there.
Guilty.
He give you a card to you. Amit, there's one more card there.
Okay, it's 3 against 1, so it's not guilty. Come on, okay. Come.
So partially guilty, sir. The news has to be there as well.
No news. No news for you. Yes. Everybody can see a different court martial this time. No, can't do. No. No.
So this is going to be a very, very difficult trial for me and for everybody else because the gracious host is on the trial. So Madhu, in your native language, your oath, please.
ఏం చెప్పినా నిజమే చెప్తాను, నిజం తప్ప ఏమీ చెప్పను.
Did you curse me?
No, no, no.
Shall we begin?
Yes.
Yes.
I think it has a voiceover also.
Okay, yes.
Dr. Madhu wanted to be.
Voice.
We had no financial disclosures. A 63-year-old elderly lady was referred to us after small incision cataract surgery, was abandoned suspecting a complete Descemet's membrane detachment while entering into the anterior chamber. Due to poor visibility, the patient was referred for a combined procedure of cataract extraction and IOL implantation along with endothelial keratoplasty. This is the clinical picture showing diffuse corneal edema with evident Descemet membrane detachment on anterior segment OCT, which looks pretty bad. The case was taken up for surgery and we tried identifying the Descemet membrane with trypan blue staining and eventually identified an area of focal loss of Descemet membrane. The anterior capsule was also torn in that particular area with some lens material spilling into the anterior chamber. Illumination from external light source was also used to aid in better visualization. We created a capsular opening from that area and managed to complete a capsulorhexis. The cataractus lens was soggy and was further dissected and delineated with control hydro procedures. Phacoemulsification was then performed specifically in the area of focal Descemet membrane loss using a combination of chip and flip with flip and chop technique with optimal parameters of 380 vacuum and 35% power using Venturi phaco machine. The procedure was supported with external illumination by scrub nurse whenever needed. Care was taken not to engage the remnant Descemet membrane fracts into the phaco probe by holding them with a blunt dialer. The phacoemulsification was done with controlled pace, cracking the nucleus small piece at a time. Cortex aspiration was done using a Simcoe cannula. IOL was implanted into the bag. The Descemet membrane is visualized again with external illumination and with trypan blue staining. The Descemet membrane was then reattached using air and a few venting incisions to aid better tamponade. Post-operatively, the Descemet membrane attached well as evident on anterior segment OCT. After 6 weeks, the patient's vision improved to 20/40 with spectacles and with regular post-operative medications. Staining of Descemet membrane with trypan blue and external illumination play a vital role in managing cases with compromised corneal clarity. Surgical tips from this particular case are to use the area of Descemet membrane loss as working area for phacoemulsification. Use optical phaco parameters and choose a technique like flip and chop, which is appropriate for this particular condition. We have avoided SICS in this case as we felt that the Descemet membrane would be further damaged with prolapsing the entire nucleus into the AC. Thank you.
Shall I begin my trial, sir? Now here, you have it all in front of you. Now this was a case in which there was a Descemet's membrane detachment. The central area was denuded. Trypan blue being put in can work as a double-edged sword as well. It will stain the capsule and the detached Descemet's, but can also enter the stroma and can create a huge visibility loss. Now, with a Descemet's membrane which is torn, detached, hanging and Dr. Madhu Daraju trying to put it across by a spatula and doing a phacoemulsification in this situation is super, super risky.
Objection.
Why did you not fix the Descemet's detachment first? Yes, there was a capsulorhexis, maybe cortical matter was there. Why not do the phaco at a later date?
Objection.
And despite everything, your 20/40 vision, your luck, your lady luck, and everything that was there, what was the specular later?
Objection, Your Honor. I think this was a case well managed. That area where the Descemet loss is there, he is clearly, the whole surgery has been done in that particular area only. I mean, there are two logic about putting the DM back and then settling it, but with the cortex, with the calyxes open and the cortex and the nucleus matter out, there could be lot of inflammation, edema, it could IOP going up. So it makes sense to do it in a primary setup, as was very beautifully shown. And the endothelium, I'm sure Dr. Tityal would say it in more scientific terms, there is a polymegathism, there is a sliding of cells, and the whole area becomes more compact. So with time, whatever little edema is there would subside. He has shown us on AIOCMTC that the DM is attached. So all those parts I think are fine. If at all you could question him, which again I shouldn't tell you, but that doesn't going to hang him. You could have asked him, why did you put the venting incision, which you didn't. So that was the only thing which again is allowed
Venting
in certain
incision is
situations.
allowed. Venting incision is fine.
Not necessary. It was not
Professor
needed.
Tityal, sir.
You have anything to say?
Sir,
Anything to add?
Yeah, venting incision regularly we don't give, sir, but in this case I had to use a lot of visco. So I was afraid that in the interface visco may be left. That was the reason I gave the venting incisions. And coming to this, I was prepared to do a DSEC or DMEC, but I wanted to give the DM a chance. And in the primary procedure, I don't prefer to do it combinedly. I wanted to do it sequentially. That's the thing. I did not go for a combined procedure because I felt sufficient amount of DM was there. When we see this DVEC and all, we just remove the central part. Still the peripheral Descemet's is quite good to compensate the remaining part. That was the logic behind not doing the combined procedures.
Whatever I saw, it was more like a scroll inside.
The
put the DM.
Yes, sir. In the ASOC, it was more like a scroll, but we went inside. It was like a V-shape torn, sir. That V-shape thing, that area we used for doing the phaco, where there was no DM.
So we'll have the specialist come in.
First thing I would say, the case was very well managed.
Sir, thank
It was a difficult case for any person, let it be cornea, cataract or any other surgeon. Once things are not visible, it's very difficult to maintain the integrity of a damaged the anterior segment structure, especially Descemet membrane. And luckily he could do a nice phaco in this patient. And there was a, Partha used to understand when you have a ruptured capsule and, that's going to create inflammation, and DSEC or DMEC in that situation was very difficult. And inflammation would be there. So primarily we have to remove the cataract and then plan out the surgery. And as Madhu rightly pointed out, this was a healthy patient as far as endothelium is concerned. Only the central area was damaged. The peripheral cell as well will take over in future. That's why cornea got so clear. But we should understand the other ways to making this effective was he did stain to see what is inside, which is very important, and use of external light source is also very important in such situation, and Madhu has done a very good job in that area.
The primary
If this
surgeon.
was my case, I would have really been worried about what is going to happen in this patient. The patient did so well.
Sir, thank you.
So,
I think the
Supreme
primary.
Judge, sir, I have one
He has one thing to add.
point to make. Even Professor Tityal accepts that he would have been anxious to do this case. Madhu Daraju feels that he is God and did this case.
Nothing like that.
I
It's a
just have a
challenging
comment.
case.
I just have a comment.
He had the courage to show it.
Madhu, you got a timely referral of this patient by a surgeon who was not competent enough to handle this complication. So hats off to the surgeon who knows that he is not capable of handling this situation. He referred to you.
And he was very
I
frank,
just have a few queries. You have got trained from an institute where the surgery which the referring surgeon has done, you are also master in that, the SICS.
Yes,
Already that SICS incision was there.
yes, sir.
Why you shifted to FICO?
Because the extent of
Let,
detachment will increase.
let him answer.
The DM was torn, sir, when we like get this entire nucleus into the thing, and while I try to deliver it, the Descemet's may come along with it. That was the reason I did not.
But we could have reported the DM first, and we have done so many cases
But still,
with
sir,
the
it
DM
was-
tear and the cataract expression. We can divide the bisect, trisect the nucleus inside
Yeah,
only.
I
And the
felt-
cataract was not looking very hard actually.
So Amit, shall we hang him?
It
No,
was
no. I'm just asking him because
SICS
the general audience,
SICS.
actually the general audience should know this because they do SICS and they should not be, like only SICS can't be done in such DM tears, only FACO has to be done. That's why I'm asking Madhu. Because the
But
audience should have the message.
There is a challenge to do SICS with a
Amit,
DM
we
flow.
should understand where he made a SICS incision. Tear was into that only, radial tear. If you try to take out, this flap will open up.
open up.
We
and-
shift to other side where Descemet is just perpendicular to the tear area, so you can manage the Descemet
I think
better.
to send the right message across to the audience, maybe this is not a suitable case for
Doing-
SICS because you never know when you're taking the lens
It's
out.
not
that
in our
the
control.
Descemet's membrane might
The
also-
primary surgeon, why the capsule was open, sir? He went into the plane of DM and he was thinking that was the capsule. And when he did the puncture, he punctured both the DM along with that capsule. That was the reason anterior capsule was. Yes. Yeah, yeah.
I think you have good hands and very good heart.
Sir.
But unless the general ophthalmologist has good hands and good heart, don't attempt these things.
Yes,
Madhu, you took the right decisions at the right time.
sir. Thank
That's
you.
good.
So Santan Gopal sir, shall we also partially
No,
hang
no,
him?
no.
No, although I like you, still, still,
It
I
was
don't
a
want to.
case very well done by Madhu. Dr. Madhu did the right thing. We would probably want to know the status of the other eye. Was there some pre-existing corneal PMD or something?
No, sir, no.
The other.
The other eye was pseudophakic, sir. It was normal. This was because of the trauma caused during surgery. only.
Okay.
Is it attempted SICS or attempted FACO before?
SICS.
SICS.
SICS, SICS.
So only a query I had was very well done. You kept saying that you were going to the area of Descemet's detachment because that was the area where visibility was there and you operated there.
No, sir,
I would-
visibility was not there, sir.
Ah.
There I didn't have the risk of catching the DM. So there I was using the external illumination to do all my maneuvers. Because otherwise the DM was open in the other areas.
So almost in the entire cornea, the endothelium, the Descemet's are detached.
Yes,
And
sir.
it was just scrolled up.
Scrolled up, yes. It was like a V, sir, like this. If you take the clock, this V was open. That was there.
I think,
Sir,
how many days post-op?
post-op 6 weeks, sir, 6 weeks.
No.
Referral immediately, sir, almost third day. Third day we got it.
I think very well done. I need not even ask. I request Dr. Devashish to do the honors.
Let's go! So Dr. Venkatesh, your oath please.
சார் நான் சொல்வதெல்லாம் உண்மை உண்மை தவிர வேறு எதுவும் இல்லை
Done? Okay.
எஸ்
Yeah.
ஸோ ஐ ஸ்டார்ட் வித் அன் அனிமேஷன் யா ஸ்டார்ட் கேன் ஐ ஹேவ் மை வீடியோ I have the audio as well. Yeah. So, honorable jury, here I am with my mixed case investigation. So, obviously, the public prosecutor wants to put me in jail. I am on the jury here. I am using my gadgets to come escape with this. So, yeah. Mixed case setting 1. So, I stent inject 1. You can see how small it is. It's actually costlier as well. No financial disclosure. It's as small as a single fingerprint. So we need to go in tangentially place it into the pigmented trabecular meshwork. Once we are in the right plane, we have to release the button and then come out. So that's about eye stent. So mixed case 1, so this is a mild glaucoma patient who is absolutely fit for generation 1 eye stent. It was a small pupil as well. You can see I had to first start with a pupil expander, BX1. In this case, I am doing a rhexis, and then everything went on well, a smooth phacoemulsification. The rhexis was slightly small to my liking, so after I placed the lens, I did some more extension on that as well. So then I tilted the microscope 40 degree towards me, and then the patient set 40 degree away to the total internal reflection for direct gonio. And when I took my eye stent inject trocar, my stent was missing. So it was there in the cartridge. So I should have planned better in the intraoperative navigation. So I had to go back, catch the stent, approach. You see, it's very difficult. High magnification. It's as small as your fingerprint. So I had to navigate it, take it. I should have planned it better, but I was lucky it was in the cartridge. So I had to take it and then go back in and then place it in the pigmented trabecular meshwork. As you can see here, I recovered well. So these were some of the initial cases when MIGS came into India in 2021 September. So I placed it well. I was able to elicit the findings as well. The proper placement finding is, you can see the episcleral venous vessel adjacent to the stent that is actually perfusing. So this is a 1-year follow-up. The IOP of the patient is in low teens from 2 medications and he is perfectly fine. So I should have planned my navigation better, but having said that, these were some maneuvers which were not really available even in videos in the initial days. So right, not 1 but 2. The stakes are even more higher. So you can see that it's eye stent inject, mixed case investigation case setting 2, Your Honor. So again, in this case, you can see a patient, a much more demanding patient, 3 anti-glaucoma medications, 21. He wanted to be free of glasses. We went for a EDOF with eye stent inject 2. You can see that a superficial implantation had happened. So when I put the heel on, my heart was in my mouth because the stent just fell there. Okay, I had to reassess myself. I thought I'll place the second stent first and then retrieve the stent which was hanging. So I thought I was okay, I'll come out and then go back in. Again, I lost it. I was shocked what happened because I can't search the eye stent, it's not like an IOL. I should have closed the trocar and come out, but I failed it because there were not many manuals or teaching videos there. So I then went back in, took it from the phaco wound, then I came out closing the trocar, and you can see that a beautiful demonstration. Then I went in, Your Honor, and placed the stent again. So I was lucky that it got caught in the phaco wound, but to my wisdom, there were not many videos or not many instructions at that time. And you can see beautiful paralimbal white blanching suggestive of the episcleral vessels that have perfused on the table. The recovery was well, and you can see the follow-up of this patient, IOP in the low teens from 22-23 with 3 medications. So I went back to my drawing board. There were not many teaching modules for MIGS here. Even after 4 years of MIGS, we went back. I didn't want the mistake that I made to the novice surgeons to make. We constructed a simulator in a metaverse, the first 4D MIGS simulator, and then I wanted my posterity surgeons to master the trabecular meshwork memory, because you can see that the dangling eye stent here, this is the main culprit that I encountered in my early days. So I didn't want my fellow novice surgeons to undergo this. So I made this and make sure trabecular meshwork mastery is the key to manage a successful MIGS surgery. You can see this is my video cassette. Initial days were tough, but 2, 3, 4, 5, 6, 7, 8, 9, 10, I've got through. Thank you.
Shall I begin the trial?
I thought you had ended it.
Yes. Now I have to tell a story. This is the story of Prasanna Venkatesh. This gentleman is a super talented guy. Super talented. But he's a strategic master. Cunningness and, if I can say, devil to rise to the top. So why does he show this video is what you should understand. He showed a video of failures. Yes or no?
Yes, sir.
And he wants me to prove him guilty, which I will, and you will all agree. But yet, what is his motive? His motive
Objection,
is
Your
to-
Honor. He's really going off track.
Can
He's
I
he's telling us some irrelevant story. We don't want to know about the psyche of Prasanna Venkatesh here.
Yes, we have to know the psyche of this
We
man
don't.
who
But
is
keep it
here
brief.
to
Keep it
sit down.
brief.
Yes, very brief, sir. The psyche of this man is to sell the product that he has made, so that every one of you and glucose, if they are here, they better be aware. He is going to sell that software program so that every surgeon who tries an eye stent will go on to that software, buy it from him, make him rich, and
So the
I
mistake,
have to prove
the
him
mistake,
guilty.
mistake done by you was you shouldn't have given him a podium presence
So
here.
first and foremost, do you plead guilty
No,
or
I
not?
think,
No
let's,
guilty.
let's clarify this right away. I think it's
Sir,
available on, the software is available free of cost to anybody.
Yeah.
Yes,
who
sir.
wants.
I was about to say that, sir.
Today, sir,
No.
today, it is like WhatsApp, free for everybody, and then it comes with
Let's
the price.
appreciate the young man for what he has done now.
I know.
I will, sir.
Maybe he'll
I
grow up to
will.
be like us. But
Sir, it's free of
So,
cost.
you plead guilty?
No, why
sir,
should he?
no.
Arey,
No way.
You have
He's
done
got-
everything
No, sir.
you have done wrong.
Our
you still
public
don't.
prosecutor fabricates a story and then he wants.
come.
Okay.
Come.
Stick to,
Let's
stick
Who
to the
loaded
case,
the
please.
science now.
Please.
Yeah.
So, the first stent you lost, who loaded
Yes, sir.
the stent?
Sir, actually, the stent is come preloaded.
No, yes.
It comes as a preloaded one. When the package was opened, ideally going back, I should be the one who should have taken it from outside the package. But that was something that hindsight, I do agree, sir, yeah. That was the first case.
So, it comes preloaded. It has to be taken by the surgeon and not by the theatre nurse. And that is what he did. Yes or no?
Yeah.
Yes, and he is guilty.
What is there to be guilty
Sir,
about?
Yes.
Sir, it comes just like an IOL.
IOL, it
yeah.
comes like a
it comes-
cartridge, no?
Okay.
Of
the defense counsel-
1.5 lakh stent
You bought
has to be done by the surgeon every single step.
I disagree with this. Might be 1.5 or 2.5 lakhs. Whether the assistant picks it up or the surgeon picks it up doesn't make a difference.
It does make a difference.
But yes, I do agree. This is you. He had sent the video to you as a public prosecutor. Why did you allow him? Why did you show a video when marketing of the eye stent is done? I'm sure when he is earning the money, he has given a bit to you also.
Yeah.
Huh? Because why the eye stent marketing was shown in this video?
Amit Podwal.
Yes.
Ruko, boss.
Don't threaten my jury.
Why not trap with MMC
So
in
no,
this patient?
I have no financial disclosures in any mixed procedures. Why not TRAB? TRAB is a very invasive procedure compared to the minimal invasive glaucoma surgery, sir, because there is an element of, we'll have to have sutures involved in it. It's an invasive procedure. MMC has its own share of complications where it has its own way of blib related complications as well. Especially for mild glaucoma cases, now not only eye stents, sir, even there are excisional trabecular meshwork surgeries like bent tab inteno, needle goniectomy, bang, KDB, and as well as stenting procedures. Trabeculectomy, there is always a chance of much more complications like hypotony, shallow AC when it's more aggressive. So when there is a moderate glaucoma, now the emphasis in glaucoma section is it's turning towards mixed procedures. It could be any mix.
What
It's
was
not
the
only-
pressure, Prasanna? Pre-procedure?
The IOP was 21 for the first
Any
patient.
comments by the defense counsel?
No. I think the surgery has just shown
Scientific,
some.
please. Scientific. Please, you're a glaucoma
What was the
surgeon.
pressure? What
Be
was the
scientific.
It is science. TRAB need not be.
The IOP
TRAB
was-
is an excellent procedure for even moderate glaucoma, but this thing has come in, and for early glaucomas, stent definitely. Though the only thing which is against it is the cost, and with the insurance cover, it
Insurance
is
covers,
promised. It is definitely one more wonderful option to
No,
look at.
we will
so
never
which is
go
what
for
he
a
has
trap.
shown.
We will never go for a drop for mild glaucoma,
Ah.
and cost is not a factor. If Prasanna is a practice wherein the patient can pay 10 lakhs, he can put eye stent. There is no
Ah,
doubt about
no
it.
doubt about it.
But what I want to know is the efficacy of the stent what you have put. There were 2 times you have dropped the stent, you have again reloaded it.
Yeah.
So there will be angle trauma. So what was your pre-IOP?
There was
and
no
what was the
angle trauma. It was
post-IOP?
fallen somewhere on the iris near the incision.
So
There
the
Therefore,
first
one-
he was
the
not
first
meddling in the
implant-
angle.
The
There was
first
not
implant
even
was superficial. That's
No,
what
no,
we also agree.
superficial, but there was no ooze or hyphema
wait,
which had to be
The
My
jury is
cleared.
giving the statement. The defense counsel should not contradict the jury.
No, during the turn of defense counsel, the jury started talking.
No,
actually-
look, please answer this question. See,
Yes.
Dr. Prasanna, when you did these stents, you had no possible business to have the second stent dislodged. It was by providence that it was caught in the wound.
No. The first stent, which was superficially placed,
One-
it has
one-
not traumatized the angle and he then inserted it in.
so can
There
I-
was no bleeding. And the second stent, it was somewhere near the phaco wound.
Somewhere near the phaco
He
wound.
had to show some complication.
it
so
had
he
to
showed.
go
Just
off.
one moment, just
This
one
was
moment.
not a complication.
No, this is a device which has recently been introduced and he has tried it right in the beginning. Visualizing the angle structures itself is a challenge. And I think there's a lot of learning that's happening now. And this was done about 1.5 years back,
Yeah,
the first one.
2021,
So obviously,
they were
whenever
not
we are
wired
getting
the-
used to a particular device, there are certain mistakes that we commit and it's good that you're showing it. I mean, fine.
So,
as
and,
far as
On
the
what grounds
ultimate-
the public prosecutor wants to hang him? I want to know that. All these are answered properly.
Answered properly.
Mild
No,
glaucoma,
let's-
stent
let's-
and mixed
let's-
season
just one
He
indication.
didn't
moment.
know what he was
Any
going
other
to talk.
comments from anybody?
So can I make a
Doctor,
point?
I just want to know the
Yeah,
Actually,
he's a-
the shunts,
a
they will
problem.
be usually done for the cataract.
Yes, sir,
when
it's
phaco is done.
It's combined
So,
along with the cataract
The
procedure,
most
sir.
important part is it is combined with phaco.
Yes.
Any glaucoma, moderate glaucoma, we can have
Yes,
a
sir.
trial.
Yes,
This
sir.
is actually another added.
Yes, sir. Sir, and there is each trabecular meshwork, just like the capsular rexes, they have a own memory. So some trabecular meshworks which are more pigmented, you need to give a slightly more axial force. Some trabecular meshwork which is less pigmented, the axial force needs to be slightly less given. So these are things only when we enter, we'll know. If you give an overpressure, you may eject the stent and it may go into the Schlem's canal, you may not even be able to retrieve it after. So when you start, that's the trabecular meshwork which is the matter, sir. So the force with which you go in, that is where you really gauge it. So everyone who's starting to do mixed surgery, the first initial
I
one
think
or two. Yes, sir.
we don't need a class now, so.
I think if slightly older surgeons have this problem, you better have stent in your coronaries. I mean, these kinds of things are okay in experienced hand, but not experienced heart or slightly older heart.
Sir, let
Because
us,
some of
let
the
us hang him, sir.
complications
No,
can
why
be-
should you hang?
No, some of these complications can be quite stressful for the surgeon, not just from the point of view of surgery, but you realize that in the initial learning stage, your heart rate is much higher compared to when you have finished doing. That's
I
one.
think my jury is talking about stents for the surgeon.
Yeah.
I think obviously he's not guilty. Well done and keep it up. Amit.
You have to leave, sir. I can't let you leave, sir. You are my only jury favor.
Not guilty का आपको ही मिलता है.
Huh? Thank you, thank you, thank you.
కోకా 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 కడితే కొర కొరమంటూ చూస్తారు పొట్టి పొట్టి కౌనే వేస్తే పట్టి పట్టి చూస్తారు కోకా కాదు కౌను కాదు కట్టులోన ఏముంది
Dr. Kavita Rao, thank you, ma'am, for being with us here.
Look at him. Look at how drama to the hilt.
As a very glamorous surgeon and a very beautiful surgeon, and I'm sure you'll be able to plead guilty for all the mischief that you have done.
Don't forget what you are.
Shall we start, sir?
Yes, sir.
Your oath, ma'am.
देवाक आणि पब्लिक प्रॉसिक्युटर आणि ज्युरीक सगळ्याक समोर दवरून हांव सत्यच उलयतां.
Shall we start?
Yes, sir. So my patient is a case of traumatic cataract with mydriasis. This was a 32-year-old patient. He came with a history of glare and decreased vision. This injury to his eye was while playing badminton with a shuttlecock. It happened when he was around 13 or 14 years of age. And the problems of the glare had happened recently, like about a year or so. And I thought in my mind that definitely there was a component of amblyopia because he wasn't sure about the exact age at when the injury happened. So with the guarded prognosis, we decided to go ahead with surgery, and I plan to do the cataract removal with repairing the, the iris also. So this was the video. As you can see, there's a zonular loss in a limited quadrant. So after doing a capsular rexes and doing a gentle hydrodissection, I go ahead with putting a capsule tension ring. Since the zonular loss was around 3 to 4 clock hours, I thought that would be sufficient. Following which I go ahead and do my phacoemulsification. It is, I just do a I do a stop and chop, and I try and get the pieces into the bag, and the intra IA is done, and the 3-piece IOL is placed within the bag. Now after that, I inject pilocarpine in the eye and try and see where the pupil is at. Sorry. So here you can see this is the final, the position of the pupil after putting in pilocarpine. So I decided to do a 4th row pupilloplasty. So you pass the Prolene needle through the opposite end of the iris and railroad it from the 26 gauge needle on this side. Once you get the Prolene out, you can use a dialer or you can use a forceps and get the Prolene out from the second, the edge of the Prolene suture. You can get that out and use a 4th row technique. This can be repeated as many number of times. As you can see, I've done it twice here. In the AC maintainer which I have used, I could have used it initially as well, but later I found that the anterior chamber was shallowing and I put it on later. I've done this twice, and I think when I could have done one more suture, but I feel at the end of this I was quite happy with the outcome. So I think the important thing in this is to look at, assess the pupil and see where the pupil is at, and you can, it's very easy. If there is not enough visibility, sometimes if there is like a corneal scar on that side, you can always use an endo-illuminator also. So here with the dialer, I'm pulling that edge of the suture out. You can then go ahead and grasp it with the forceps and get it out, I think. Some problem with the video, and this was the patient. He improved to 6/18 parts, and he was quite happy because his symptoms of glare also were taken care of. So thank you.
May I begin the trial? So, Director of Cornea, Cataract and Refractive Surgery Services, Aditya Jyot Eye Hospital, unit of Dr. Agarwal's Eye Hospital. Yes. Financial interests in the 4th row pupilloplasties, madam?
Unfortunately, none.
Unfortunately, you are unfortunate. You should have financial interests, at least make money. Now, again, Aditya Jyot Eye Hospital, Agarwal's Eye Hospital, what poor quality of recording.
The content was conveyed. I think objection, Your Honor. This time the public prosecutor is crossing his limits.
Ma'am.
It is science to be discussed.
Ma'am, yes. The capsular rexus in such a case has to be very appropriate, very patient, very gentle, very nicely done, and everything, every step you must show whether it was done by a forceps, it was done by a cystotome, and to show the whole rexus. Why did you not
It
show?
was a 4-minute court-martial video. She can't be showing rexus for 1 minute.
The importance of rexus is highly important in this space.
Afterwards, you see that the rexus
Point
is
taken,
round, no?
Point taken, please proceed.
The CTR placement. Why did you fast forward the CTR placement? Could you not place it in properly? You did place a CTR.
Yes.
The next thing that is very important, Dr. Kavita Rao, placing a 3-piece lens in the bag, and when the lens is opening, you need to maneuver the haptic in such a way that it does not impinge on this subluxated bag in the vertical direction. The maneuver should be such that the haptic opens horizontally, which it did not. Did you note that?
No, that was not a big
No.
issue.
I think, no, just one moment. I mean, because we need to send across some good
Yes.
messaging. The first and the second point I don't think is important.
But I can deal
it was
with it.
very obvious that
How
when
did the judge come into it in the beginning itself?
when
Oh, she questions the judge. Sit down.
But I have to talk here.
the haptic, the leading haptic was opening vertically and point towards the posterior capsule. That was the time when I had my heart in my mouth, because obviously you should have maneuvered your hand in such a manner that it opens up more horizontally. No.
See, how the haptic, I think I need my turn to talk. Yeah, he always does it
At home
outside the
also.
court also.
Chitra, you're in deep trouble, you know. The Supreme Judge is with the prosecutor.
No, I think yes, the rexis, she could have shown little more, but then the rexis was round at the end of it. And she had the courage to place the CTR. You know, the challenges of placing the CTR right in the beginning, it's its own story. And she showed an uneventful surgery. What are we talking about the haptic being dangling and all that? Haptic was finally placed optimally. It was there in the area of zonular weakness. So besides the CTR, that haptic also stretched the back. So all that was right. So why don't you close this? We are just searching for problems where none exist.
No, we need to give a message. The way the
message was-
three-pass, three-piece lens is being implanted, I agree with our jury,
Yeah.
chief jury, supreme judge, that the haptic was going down. The leading haptic was totally perpendicularly down. So to give a message to the audience, you have to maneuver your wrist when you are implanting a three-piece IOL.
Yes.
Second thing I wanted to ask Kavita, you have placed a CTR. How much was the dialysis? The dialysis was looking very big. Why you didn't go for a CONIS instead of a CTR?
No, it was around 3 clock hours.
It's
Three
3
clock
clock
hours.
hours and
Then
a
it's
traumatic
okay.
cataract, non-progressive. I think
Then it's
we
okay.
need not overdo it.
It's okay. मेरे से मत लड़ो. मैं घर नहीं आ रहा हूँ.
If you have a good, viscoelastic filled bag, then you are safe sometimes. But if the viscoelastic comes out during the three-piece lenses, then sometimes this haptic can tear the posterior capsule also. So little carefulness is required in manipulation of a hand. Sometimes you can tuck the haptic in the cartridge so that it opens like a routine lens also. That's
So,
done.
partially hanging, sir?
No hanging.
Partially hanging, yeah, correct.
All
That is more difficult than a full hanging,
Oh, you mean we are
No,
planning for the hanging of the public prosecutor? I agree
No, I
with you.
think it was well done. One other thing I don't understand is traumatic mydriasis is usually the entire pupil which gets dilated and fixed. And usually it's an encirclage suture that's needed to shrink it, rather than you manage to do it in just in one quadrant and then you got quite a regular pupil. I think you're very fortunate.
Nowadays, with
I mean,
traumatic
otherwise,
they
no.
do the pinhole pupilloplasty only. Encirclage
then it
is
has
not
to be done in-
Encirclage, it has to be come 360 degree.
Because you
For
have to
traumatic mydriasis,
uniformly,
4
concentrically
through
shrink it.
pupilloplasty is if you have a sphincter tear or a defect, a localized iris defect, then we go for a 4 through pupilloplasty. But for this, an encirclage is what is
But
recommended.
at the end of the surgery, the pupils seem nice.
Looks nice.
Yeah.
But anyway, I think it all depends on who's doing it.
So not guilty, please.
Madam also looks nice.
Okay.
So not guilty.
Not guilty.
Dr. Reddy, you can have the pleasure of.
Public prosecutor,
Yes.
there is conflict of interest in the jury. You still want to go ahead with this jury?
I have full trust in my jury. My jury is an honest jury and it will pronounce guilty if guilty. So, Dr. Sandeep, with hand on your heart and your oath, please. In your
Morning,
language,
everybody.
in your local language.
చెప్పేదంతా నిజం చెప్తాను, నిజం తప్ప ఇంకేమీ చెప్పను.
This flower.
So I'll be presenting a case of, I call this a posterior direct chop. This is a case of dislocated nucleus into the vitreous cavity. So this was a case where a surgeon has referred me a case of a nucleus drop while doing a phaco surgery. So what I have done is I don't want to use any second fragmentome. Instead of using a fragmentome, I already have a phaco machine right next to me. So what I was doing is I was using two instruments simultaneously, the phaco machine as well as the vitrectomy machine. And you can see I got the nucleus into the anterior chamber, and I'm supporting the nucleus with the cutter from posterior side, and I'm doing a direct chop from the anterior side and chopping from the posterior side. That means I'm using the cutter as a chopper from posteriorly. I'm holding the nucleus with the phaco probe, and as you can see, I'm doing a direct chop using the cutter as a chopper. And the anterior chamber is very well maintained using a anterior chamber maintenance, the AC maintainer, so that the AC is deep and the cornea is not well affected because of the deep anterior chamber that is maintained. So basically you will have to use two machines simultaneously. You have to divide your brain in such a way that you are controlling the phaco machine with your left leg and the vitrectomy cutter with your right leg. And it is completely that you have to divide your brain to control the two machines simultaneously. So once the nucleus is managed, the pieces that have shattered into the vitreous cavity are removed by simple aspiration with a cutter. Whatever the small pieces that have been shattered into the vitreous cavity have been aspirated completely. And then I have placed a 3-piece IOL into the sulcus. And I always generally use micro forceps to guide a 3-piece IOL into the sulcus rather than using the routine McPherson's forceps. The maneuvering becomes much more easier using a micro forceps. So this is the end of the surgery. So this avoids making your incisions larger, or you can avoid using a frag and making an extra incision over the sclera. So I utilized all the incisions what the phaco surgeon had made in the anterior chamber and did not use any extra incisions to remove the nucleus out. Thank you.
Can I begin my trial, sir? Yeah. So while chopping this particular nucleus or the fragment removal, if a small fragment drops, again, how would you manage that? Number one, why will you not use a fragmentome? Why?
Yes.
A fragmentome comes with great advantage to the VR surgeon. You do not have to use two machines in such a case. Yes?
Yes.
You agree?
No,
Please
no,
sit down.
I can tell you
Okay.
what. We
The-
learned something from this case.
No, there's not much to learn from this case. The only thing that you have to learn is you have to optimize your machine to do a surgery. That is what you have to learn. And if you can do it well, if you know your parameters well, then you will do it well. So it is absolutely rational to do two machine surgery in such a case. And that's my main intention of finding you guilty.
The things for him, which was very interesting for me to learn when I saw his video, is that it was a hard nucleus. We need to understand that when you're fragmenting a hard nucleus in the vitreous cavity, he's done a good vitrectomy and he has ensured and he's brought the nucleus forward. You know, there is, with the shock waves which are created, there could be macular edema which can happen. There could be PV retinal detachment which can happen in these eyes. And those pieces which ricochet when you are doing that phacoemulsification in the vitreous cavity can itself harm the retinal structures. So it makes sense if you could do a good vitrectomy, get the fragment forward, ensure that there's no vitreous in the anterior chamber, do a tricot check and all that, and then you're able to deal with it with the kind of skill set which this surgeon had, it can be done. No question of endothelial damage. If you just inject viscoelastic, we were ready to do the whole phaco in the anterior chamber. It went into the posterior chamber. But there are so many things which happen in the vitreous. The only other thing which are also important is, you know, there is occlusion. All those things when you're using a fragmentome, the vitreous. So if there's surge, there could be hypotony, and that hypotony can also damage the retina. So there are a lot of issues which are happening if you're cutting a hard vitreous in the vitreous cavity. So these are the major points. Am I right or not?
Yeah.
Yes,
You
sir.
have anything to say?
I just want to add that when you are handling hard the nucleus with a fragmentome, as you all know, the fragmentome does not come with a sleeve. The scleral burns are very common. When you have a scleral burn, even if you suture them, the hypotony postoperatively is very common. But I think the wound integrity will be best for a corneal wound rather than with a scleral wound. Especially when the fragmentome always comes with a 20 gauge fragmentomes, you don't get a smaller gauge fragmentomes at all.
No, but here what also you are actually putting into a lot of harm and hurt is the amount of phacoimmunology that you're doing right in very close to the proximity of the cornea. So why do that?
It is in the pupillary area.
No, it's not in the, how can it be
No,
in the
no, no,
pupillary
just
area?
1 minute. I mean, let's have comments from the jury.
So basically, we have good quality fragmentome. I mean, I won't go recommend this. The nucleus was not so hard. With the fragmentome, it could have been removed, number one. Number two, you prolapse it into the anterior chamber. You used the Blumenthal technique. Your defense counsel is saying with the visco, it could have been protected. But what we saw in the video was the Blumenthal technique was used. You were chopping the cataract into the anterior chamber. So endothelial cell loss, we have not accounted into that. So that's not a safe technique actually in this type of situation, number two. Number three, you finished the surgery. What was the status of the cornea on POD1? That is important also.
The cornea was very clear, sir.
Cornea was very clear.
I had done this technique quite a number of times.
Yeah,
The
so
AC
you might
maintenance-
be skilled, you are efficient, but for the audience, what I would like to say is, we have good quality fragmentome. The nucleus was not so hard that it couldn't be removed with the fragmentome. Should go ahead with the fragmentome. And if at all you want to prolapse into the anterior chamber, please do it under a viscoat cover and not a Blumenthal technique. That's all. But it is very nicely performed surgery. And if the cornea is clear on first post-operative, that means heroic surgery.
No, no, towards the end, you could implant the, three-piece IOL onto the rexis margin. You could do very nicely.
Yes, sir.
What I would have done, once the nucleus has been prolapsed in the anterior chamber, I would have taken the IOL as a scaffold, put it there, and do a nice chop by the anterior root, which we are used to,
Yes, sir.
and manage the nucleus effectively.
Yes.
Also, that can also be done.
Yes, beautiful
Your
suggestion.
technique will be very good if there is no support of
True, sir.
intraocular
True,
lens.
true.
There you can't use it.
There,
Otherwise,
at
for
that
us,
point of time, I did not
intraocular
get
lens
the-
will be a very nice scaffold to do
Yes, sir.
complete
I
this
didn't
and
get the
do a
idea of
vitrectomy.
putting a scaffold.
Yeah.
Good
You are
idea.
left-handed surgeon,
No, sir, I'm right-handed surgeon.
so you were able to hold the
GRA.
phaco
I
with
can
the
do
left hand and do
I
it.
can do phaco with both hands.
No, I mean, we
I
need
can
to
do it with both my hands.
appreciate that this is another way.
Another way.
I mean, a fragmentome would require definitely a suture. So essentially, the entire surgery becomes sutureless. So this is one thing, and of course, as Professor Titial pointed out, that probably some scaffolding would have been better, because I was wondering, I mean, how can you just keep it balanced with a cutter, the nucleus at the pupillary area, and
He's both
chop
an
it?
anterior and a posterior segment
I mean,
surgeon.
it requires a skill.
Skill.
So I mean, we need
Sir,
to
would you
find a better
recommend
way.
to the Disha surgeons to do this technique tomorrow?
He would if they can do it.
They might, because obviously, see, you must understand, when you are doing phacoemulsification, you are committed to a sutureless rehabilitation of the
Yes,
patient, and this patient has a nuclear drop and is being managed the same day.
Yeah.
So, I mean, if the patient gets out of the
I think,
operation theatre
no,
without a
I-
suture, I think it's fine.
I think, we should set the right message across. This technique might be a great technique for someone who doesn't have access to a fragmentome. But for a good vitreoretinal surgeon, a very competent cataract and...
No.
Please, you had your say. I mean, a vitreoretinal surgeon Definitely doing it in the mid-vitreous cavity using a good fragment, where anyway you have to finally go in search of the nucleus fragments which are dropped down and pick it up. So the message across, yes, there was a stage when we didn't have access to a fragmentome. Maybe at that stage I would have performed this. But now with competent vitreoretinal support, using the fragmentome, and this was not a hard nucleus. This was a white cataract, but it was just a moderate cataract. Using it in the mid-vitreous cavity would have been more efficient, less damaging to the endothelium. But then finally it's the results which matter, and you are the host. So you're not guilty.
Can we have the jury, the man behind the machine there?
Really, it requires a highly skilled this thing, because you are using two instruments, the vitrectomy and the phaco with the two legs operating. You have to divide the brain into two halves, one for phaco and one is vitrectomy. It is very difficult.
Yeah, it's quite challenging. Admitted, it's quite challenging just to, avoid that
one
suture.
other technique and a
The
brilliant way
one
of doing
suture.
it.
Yeah.
And all those complications which I said were discussed with me by a retina surgeon. So it's not that I fabricated it. These things happen when you do
Yeah, you
use
do
fragmentome in
fabricate,
the
madam.
retina.
We accept you fabricate.
I don't fabricate.
Okay. Jury, I think Dr. G.R. Reddy.
रातों का है ये उजाला बर्फ गुमसुम ही मचाए ये तो खुर 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 रफात कर नॉन स्टॉप खुर खुर खुर